Next, I invite Dr. Sudha V to talk about HCQS drug toxicity. She is the professor of ophthalmology in Government Medical College, Idiki, and she is a clinician par excellence in medical retina. Welcoming her for the talk.
Good morning to all of you, and thank you, Deepa and Sindhu, and the entire Ernakulam team for giving me this opportunity. So my topic was given to me was chloroquine toxicity, but it is not actually chloroquine which is toxic now, it is hydroxychloroquine. And since the speakers have spoken a lot about all these manifestations, I'm not going to go into the detail. I'll be just highlighting some important points. First thing is, what is the dose that is usually given? Now, chloroquine tablet is available at 250 milligram and hydroxychloroquine is available at 200 milligram dose. And the usual given is 200 milligram per day of hydroxychloroquine. Chloroquine is now very much restricted to only few drugs like amoebiasis and malaria, which is actually given as a few short period. Malaria is given once weekly treatment or something. So it's not really a big issue. The issue is when you give it for a long time. That is in collagen vascular disorders. And it had been used as an irrational use in COVID, which is not very useful. But the same thing at the same time, if you know that the cumulative dose of 1000 grams is supposed to be toxic, and this comes after 7 years. So it is not really a very toxic drug in that sense. But for those who are getting collagen vascular disorders, they will go beyond that 7 years. The other thing important here is that side effects of the eye are later. The side effects of the body come first. So we can detect it early. So things like pruritus, headaches, when the patient comes to you with these side effects or major side effects like cardiac conduction defects, think about this toxicity. And there you can stop before it goes on to become a retinal toxicity. So the other ones are skin hyperpigmentation, cytopenia, and neuromyotoxicity. So ocular toxicity, we don't say 1000 grams now. We say anything more than 5 milligram per kg per day. But how many of us actually calculate it per day dose? We just give 200 milligram BD. That is the dose usually given. But anyway, if it is 5 milligram per kg per day for hydroxychloroquine and greater than 2.3 milligram per kg per day for chloroquine, it can be toxic. And the toxicity appears at 5 years of use, more than 5 years. And this toxicity is not insignificant. Around 7% people do get toxicity after 5 years and 20% after 20 years. And especially if they have renal failure or there is a use of tamoxifen, or if there is a pre-existing macular disease. Now, why a pre-existing macular disease? That is because we no longer can distinguish what is the problem. So you need to know this pre-existing disease and polymorphisms. So what is the mechanism has already been told to you. It is maybe damaging to the cones or rods, but more likely it is connecting to the RPE and causing damage to RPE. Now the common one which everybody says is bullseye maculopathy. I'll just like to say something. Before this appears, the patient will give a fact that he is having a central scotoma. So if you're very, very careful, even before this, you can ask the patient. So ask the patient's history. This is a late manifestation. By the time this comes, we are already too late to do anything. So ask the patient every visit if he is having a central scotoma, if he is having any blurring of vision. And this is one of our patients who came with an unidentified visual loss. On fluorescein angiography, you can see those rings. So that is bullseye maculopathy. And most important here would be to do the fields. After all these tests, the fundus photographs, everything, you can see that the most significant is the field. So the field defect is more likely to come first. The symptoms and field defect is more important here. But in Asians, remember, bullseye is not the predominant finding. It is said that this is mainly a Korean study, so we don't really know in India. But they have said that it is a study where the pigmentary changes 8 degrees from the fovea, that is along the arcade and nasal to the disc. So we may get this kind of a change. And here you will see this more on the fundus autofluorescence and the 24-2 field. So 10-2 is not significant here, 24-2 field. But remember, any central defect in a 24-2 field has to be confirmed with a 10-2 field. So once you get a change, confirm it. So 10-2 is necessary, but first do the 24-2 in Asians. So any abnormal, you can get changes, as she said, in the retinal periphery also. There are certain cases because chloroquine or hydroxychloroquine is given as an immunomodulator. It is given for small lung cancer and graft versus host disease in very high doses. So in these kind of patients, you can get an early toxicity even after 10 or 11 months. Other changes I'm not going to go for. You can get old changes like RP. The significant here is not the changes, because by the time changes come, it is too late. So what is the prevention? Now, there are well-defined guidelines the American Academy has told us. So the maximum we've said use is 5 milligram of hydrochloroquine, and chloroquine is 2.3 milligram. And annual screening should begin only after 5 years. But fundus examination within 1 year is important, not to detect toxicity, but to detect if there is some other disease which could confuse the toxic changes. So that is important. It is necessary to do a fundus examination. It is not necessary to do a baseline field test. That is up to you. If that patient has got glaucoma or something else, you can do a field change. But there is no need to do an OCT or a field at the first year. So the test should detect before RPH damage has occurred. So as most important test, after 5 years, we have to do a visual field. And though the standard is 10-2, 30-2 for Asians. Any single spot, repeat the test with a 10-2. SDOCT, multifocal ERG is the standard, but that we don't have most of us. So you can manage with the thing. The point is that if one of the tests is abnormal, you should do a second test. 2 tests abnormal will confirm toxicity, most likely. So another thing, if the patient has a small stature, now how this dose is calculated, initially it used to be calculated on the ideal body weight. That means a person's weight plus height used to be considered. Now in that case, small stature people will get toxic. Similarly, an obese person will get more. So that used to be there. Now it has changed from ideal weight to actual weight, but even actual weight problems will occur, that thin persons may be getting overdoses also. That is also part of it. So anyway, obesity, small stature people may need early screening, and liver or kidney disease, as already said. Tests no longer recommended are color vision. There is no point in doing it. Amsler grid, it is not an optic nerve toxicity. We know damage is occurring. Damage has already occurred by the time these abnormal tests are occurred. So we don't need any of this. Baseline retinal photography, ERG. ERG is a very diffuse thing. So FFA, no need for these invasive tests. Visual field, do the visual field, do them in a regular screening method every year, and you will get the changes. Contiguous points, remember contiguous points in the central area. STOCT, there will be a flattening of the depression. Now this flying saucer sign is a late sign, we don't really need to do, but basically that is because the foveal depression is flattened and parafoveal changes have occurred, thinning has occurred, so it looks like a flying saucer. But multifocal ERG, if you see those changes, you see that marked area, that is the infranasal quadrant where you get reduced amplitudes of this multifocal ERG. ERG is a diffuse test, but multifocal ERG is for macula. So when you get multifocal ERG, just check the amplitudes in various areas. If the amplitude is down in a particularly contiguous area, that is definite sign. Newer tests are there like microperimetry and adaptive optics. They're very good, but I won't go into that further. Cornea verticillata, she's already said it's a reversible phenomena, so it's not really important. Why is retina not reversible? Because the half-life of chloroquine and hydroxychloroquine is big. So even if you stop, the drug will be in the body. It will take time for excretion. That is why the damage keeps occurring. So you have to stop before that. So let's just for the management, when you are selecting a patient, if it's a non-Asian patient, do a 10-2 field. If it's an Asian patient, do a 24-2 field. If all tests are negative, fine. Just keep repeating the screening. But if they're suggestive, do the second test. Okay, if the second test is also positive, most likely you go in for that, or you can do a multifocal ERG. So you'll have to stop the drug when 2 tests are positive. Then if there's 2 tests are uncertain, still you're not very sure, field changes are there, then you have to go in for a multifocal ERG. And the drug has to be stopped when you see the problem. So that is the most important thing. And as I've already said, earlier the retinopathy is recognized, greater the chance of visual preservation. Thank you so much.
Well, in comparison to ATT, in HCQS we had more gray areas as to when the screening was to be done. And now the awareness among physicians is also increasing as to the first screening to be done in the first year itself. Initially it was done after 5 years of starting therapy, but now they are sending more patients. Even before initiating treatment, as a baseline evaluation also, they are sending patients. But when the patient comes to us, what are the things that we have to document? That is our confusion. So as Madam mentioned, in the initial stages, a fundus evaluation, good fundus evaluation itself is enough. And later on, in the follow-ups after 5 years, we have to give importance, especially to the fields as well as to the imaging. Thank you, ma'am, for that very informative presentation.